I'd like to welcome Dr. Dinesh Singh.
Yeah.
He has done his MD in 2012 and DM Neurology from Amrita Institute of Medical Sciences and Research Center in 2016. He had brilliant academic career. As you can see, he has won 6 gold medals in MD Medicine. He stood first in university in DM exam. In 2021, he received the prestigious Golden Aim Award for Excellence in Leadership in Healthcare and his title of Most Preferred Neurologist in Mumbai. At present, he is practicing at Neuron Advanced Neurocare Center at Borivali West. Today's topic is first approach to first seizure and seizure mimic. We welcome you, sir.
Thank you. Okay. Good morning, everyone. Am I audible? Yeah. Okay. So I thought, as usual, I don't think I've discussed this topic at BMB. So I thought this is a very important topic as a primary care physician, approach to first seizure and seizure mimics. So there will be a lot of patients coming to you. You must be called at home saying that, अरे फिट आ रहा है या कल फिट आया, मेरे बच्चे गिर गए, ट्रेन में खड़ी थी, ब्रिज पे खड़ी थी, कहीं गिर गई, तो अभी क्या करना चाहिए, अभी फिट का दवा चालू करना चाहिए, फिट है क्या है. So this is a very common thing. I think all of us must be seeing at least 1 or 2 patients of falling in the line in a bus or, at the railway station or having seizures at home. So how do you approach a first seizure and what are the seizure mimics and how do you differentiate a seizure from a seizure mimic is what I thought I'll discuss. Now, usually I keep everything very case-based. Here initially first 10 minutes, I just want you to understand a little bit of theory so that you can understand the cases as we go ahead. And how do you approach a first event? I would not call all events as seizures. We'll keep it as paroxysmal event. Whether it's a seizure or it's a seizure mimic, we'll understand as we go ahead in the talk. So first paroxysmal event, you should always ask yourself these questions whenever you're encountered with the first paroxysmal event. First thing that I want all of you to understand is seizure or fits is a symptom. It's not a disease. A lot of people come to us saying, "Kya bimari hai? Mere ko fits ka bimari hai." Fits is not a bimari. Fits is a symptom, just like fever. And epilepsy is a disease. So fits or seizures is a symptom of epilepsy, is the main thing that I want you to understand. Now, whenever you're dealing with the first paroxysmal event, you should ask yourself whether it is a seizure or it is a seizure mimic. Now, there are 5 seizure mimics that you should understand. One is syncope, which is very common. Cardiogenic syncope. TIA, it can mimic a seizure. Non-epileptic events and migraine, which can be a seizure mimic. So these are the 5 seizure mimics that you should always keep in mind. Now, when you feel that it is a seizure, you should always try to classify it into 4 types. First, symptomatic seizure. Second, provoked seizure. Third, idiopathic seizure. Fourth, whether it is an epilepsy syndrome. And then once you have classified into one of these 4 categories, you should ask yourself, now will you call this event epilepsy or it is just one episode of seizure? So I'll tell you what symptomatic seizure, provoked seizure, idiopathic seizure means. So first of all, what is a seizure? This is a very, very technical definition. It is a paroxysmal event due to abnormal, excessive, hypersynchronous discharge from an aggregate of CNS neurons. So that's a very complex definition. You don't need to remember all this seizure definition. What is important is a practical definition of epilepsy. So the patient will come and ask you, एक बार fit आया, मुझे epilepsy है क्या? So you should be able to answer him whether they have epilepsy or not. Because the moment you say they have epilepsy, you have to start treatment and you have to continue treatment. We don't know for how long. That depends on what epilepsy it is. So this is a practical definition of epilepsy which was put forth in 2016. So epilepsy is a disease of the brain which is defined by any one of the 3 conditions. Any one is enough. The first condition is at least 2 unprovoked seizures occurring more than 24 hours apart. So you get a seizure today and you get a seizure after 1 hour. That is not epilepsy. There should be 2 unprovoked seizures which are 24 hours apart. आज आया 1 हफ्ते बाद आया, आज आया 1 महीने बाद आया, आज आया 6 महीने बाद आया. 2 event आया, you have to tell them that this is epilepsy. Cause ढूंढते बैठेंगे. However, if you have just one seizure, the patient comes to you immediately after one seizure and they ask you, do I have epilepsy? So how do you answer this question? So when you have one unprovoked seizure, what do you mean by unprovoked? No hypoglycemia, hyperglycemia, hyponatremia, hypernatremia. That is unprovoked. So when you have one unprovoked seizure, but on the basis of history, on the basis of EEG, on the basis of MRI, if you're able to predict that in the next 10 years, this guy is going to have another seizure, you will call it epilepsy. And what are the parameters to predict that I will tell you in the next slide. And third, if you diagnose an epilepsy syndrome, one of the commonest epilepsy syndrome is absence seizures. That's an epilepsy syndrome. So if you diagnose absence seizures, you have to tell them, okay, this is a kind of epilepsy and you take treatment for long. And the other common syndrome is juvenile myoclonic epilepsy that I will show you in the slides as we go ahead. So one of the three, two or more than two unprovoked seizures more than 24 hours apart is epilepsy. If you get one seizure which is unprovoked and on clinical, radiological, EEG basis, you are able to tell the patient that उनको 10 साल में 60% chance है कि वापस fit आएगा, you can call it epilepsy. And third, if you are able to diagnose an epilepsy syndrome, it is epilepsy. So how do you predict? Abhi suppose one unprovoked seizure, patient comes to you with one unprovoked seizure, and they ask you, अच्छा तुम बोल रहे हो, कैसे बोल सकते हो कि मुझे वापस आ सकता है? 10 years में 60% chance है कि मुझे वापस आएगा. So how do you predict? There are clinical parameters, MRI parameters, and EEG parameters. So what are the clinical parameters? If the first unprovoked event occurs in sleep, there's a very high chance that the patient will get another seizure in the next 10 years, 60% chance that he'll get it in the next 10 years. So if it is a sleep seizure, you should start anti-epileptic drugs. If the history is suggestive of a remote symptomatic cause, what do you mean by remote symptomatic cause? Means if the patient tells you, मुझे आज fit आया, मेरे को 10 साल पहले एक मेजर रोड ट्रैफिक एक्सीडेंट हुआ था और मैं हॉस्पिटल में एडमिट था, उसका डिटेल्स नहीं है मेरे पास, लेकिन तभी सीटी स्कैन कराया तो उसमें बोला था अंदर इंजरी है. So if they give you a history that they had a remote traumatic brain injury or an old brain insult and they have a seizure now, you should always start them on anti-epileptic drugs. If you do an MRI and MRI shows an old scar in the brain and they've got a first seizure, start anti-epileptic drugs. If you're doing a neurological examination, suppose it's a child, an 18-year-old child who comes to you with the first seizure, and you know that there is a history of global developmental delay, autism, mental retardation or slow mentation, you should offer them starting anti-epileptics. Or if the EEG is abnormal, you get a first seizure, you do the EEG and the EEG shows epileptic abnormality, you should start anti-epileptic drugs, even if it is the first seizure. If they have a family history and you get a first seizure, discuss with the patient and the relative. And my suggestion is any elderly, if you have ruled out cardiac cause for a seizure, you should start them on anti-epileptic drugs, even if it is a first seizure. So these are a few predictors. This is very simple clinical MRI, EEG based predictors. You can start medicines if any one of this is positive. Now, how do you classify the first seizure? So basically, you can try to classify them into acute symptomatic, remote symptomatic, provoked seizure, and if you don't get any cause, it is an idiopathic epilepsy or a primary generalized epilepsy. So what is acute symptomatic seizure? Acute symptomatic seizure means any seizure that occurs within 1 week of an acute brain injury, like within a week of stroke, within a week of hypoxic brain injury, within a week of subdural hematoma, within a week of meningitis, encephalitis, or within 24 hours of any metabolic derangement like a hyponatremia, hypoglycemia. So these are acute symptomatic seizures. These are the commonest causes of acute symptomatic seizures. Hemorrhagic stroke is the commonest cause. CVT, cerebral venous sinus thrombosis, ischemic stroke, subarachnoid hemorrhage. Amongst the infections, neurocystic sarcosis is very, very common. Tuberculosis, second, herpes encephalitis, meningitis. In trauma, subdural hematoma, road traffic accident, post-cardiac arrest, and very, very important, hypertensive encephalopathy, which is also called as PRES or eclampsia. So these are the commonest cause of acute symptomatic seizure. Now, when you have an acute symptomatic seizure, do you start anti-seizure drugs? Yes, you will need short-term anti-seizure drugs. Long-term therapy may not be required, usually 3 months, 6 months. What is important is whatever causes I showed you in the previous slide, treat that cause. Mostly anti-epileptic drug will not be required. So that is what you mean by acute symptomatic seizure. Now we'll go to the next category, that is provoked seizure. So provoked seizure means there is a provoking insult, mostly metabolic, and you get a seizure. Commonest, hypoglycemia, hyperglycemia, hypocalcemia, hyponatremia. These are the commonest cause of provoked seizures. Then drug intoxication, cocaine addicts or amphetamine addicts can come to you. These are provoked seizures. Very, very important, alcohol withdrawal, benzodiazepine withdrawal. Somebody who's been on lorazepam, they stop the medicine, they get a seizure. baclofen withdrawal, somebody who's on liofen for a very long time, they get a seizure. Now, what is very, very important is medication-induced seizure. I want you to remember only 3 drugs which are very important and try avoiding them in patient who has epilepsy. One is quinolones, that is very important. Tramadol, don't give them as a painkiller for patients who have epilepsy until and unless it is very much essential. And third is bupropion, which the psychiatrists use. Bupropion or clozapine, these are common drugs. There are a lot of other drugs which can cause seizure, but these 4 always remember. So this is provoked seizure. Do you need to treat provoked seizure? No need to treat provoked seizure. You just treat the cause. No long-term, no short-term therapy required for provoked seizure. Now coming to the last category, that is remote symptomatic seizure. So remote symptomatic seizure is that seizure which occurs due to an old or a pre-existing brain injury, like a previous head injury, a previous CVA, any congenital CNS disorder, a previous hypoxic brain injury. If you have any of this and you get a seizure maybe 6 months, 1 year, 2 years after the event, that is called as remote symptomatic seizure. So whether to treat or not, yes, you need to treat. You require long-term anti-seizure therapy in these cases. So you can see the scan here. There is a scan of the CT which shows a small calcified granuloma. So that calcified granuloma has been there for many years and he gets a seizure. So will you treat this? Yes, you have to treat it because that calcified granuloma will never ever go. It is calcified, it is always going to remain, so it will never go. This is a scan of the MRI on the right side, which is showing this hyperintensity and hypointensity there in the frontal lobe. So this guy had a major road traffic accident 10 years back. He got a seizure now. Will you treat this? Yes, you will, because this scar is never going to go. This is called as scar epilepsy. So this is remote symptomatic epilepsy. So now this was all the theory. Now we get to our cases because knowledge is of no value until you put it into practice. So it's now time for action. So this is the first case. All of you answer on the basis of what we have discussed now. So this is a 25-year-old. First seizure occurred while playing cricket. He had tonic-clonic movements, tongue bite, frothing from the mouth, no family history, examination normal, MRI brain, EEG normal. He was an ethanolic. He stopped ethanol since the last 4 days. He was started on phenytoin by his family physician and referred to me. So what kind of epilepsy it is? It is an acute symptomatic seizure, or it is provoked seizure, or it is a remote symptomatic epilepsy? It is provoked seizure. So acute provoked will not go together. It is provoked seizure. So will you treat this? You will treat it maybe initial few days. Once he is off alcohol for a long period of time, you can stop anti-epileptics. So because the provoked seizure, you just need to treat the cause. You put him on an alcohol withdrawal regime and take off his anti-epileptic drugs. So this is not epilepsy. What is the cause for the seizure is alcohol withdrawal. How long to take drugs? Not required. You can just stop it in about a month's time. So alcohol withdrawal seizures can occur up to 3 to 5 days. So that is why the classification is very, very important. It's a very practical classification. And these are the questions patient will ask you. Daru piya fit aaya. See, anybody who gets a seizure, the patient, everybody panics around him. And they are more worried about the medicine and the side effect of the medicine. So they will ask you this, medicine side effect hai, kab tak lena hai. So this classification is very, very important. So alcohol withdrawal, no need for medications. You just put them on an alcohol withdrawal regimen and they'll be okay. Now coming to the next case. So this is, one sec. So this is a seizure. Okay, he's got this tonic posturing and some clonic movements of the hands. His relatives are holding him. He's getting an active convulsion. Okay. This is an MRI. MRI shows a neurocysticercus lesion in the left parietal lobe. So whether it is provoked, acute symptomatic or remote symptomatic? Acute symptomatic. Provoked is different, acute symptomatic is different, remote symptomatic is different. So it is acute symptomatic because this is an acute injury. He's got edema also around it. So this is an acute symptomatic seizure. Will you treat this? Yes, you will, because there is edema around the lesion. So you have to put him on an anti-epileptic, but at the same time, you have to treat the disease. So you put him on steroid, you put him on antihelminthics, and how long will the patient take the anti-seizure drugs? Maybe 6 months, 1 year, you can take the medicine off. But what is important is you have to treat the cause. So this is an example of acute symptomatic seizure. The first alcohol withdrawal was provoked because he withdrew alcohol, he got a seizure. That was a provocating factor there. This is a neurological disease. It's an acute disease because you got edema around the lesion. So you treat it, but you treat it for a short period, maybe 6 months, 1 year, that is enough. It's a provocating factor. Usually we say metabolic. That term is basically, it merges into each other, but you can still, demarcate. Provoked seizure, you don't need to treat at all. This guy you'll have to treat for 6 months at least. Till the edema settles, you'll have to treat. Now, this is an elderly male with first seizure, 65-year-old. He had a CVA 20 years back. At present, he was completely asymptomatic, presented with one episode of GTCS. Examination was normal, EEG was normal. His MRI showed a left MCA territory old gliotic lesion. What is this? Acute symptomatic, remote symptomatic, or provoked? Remote symptomatic. Yes, because he had a stroke 20 years back and this is just a scar of that. Will you treat this? Yes, and this will require lifelong treatment. Got it? So I think I'm getting clear here. Right. Now this is a young child, 14-year-old, multiple episodes of right facial twitching, right upper limb twitching, almost 10 to 15 episodes in a day since the last 3 days. Examination normal, MRI normal, EEG normal. I'll show his video. So you see his face, he's got a twitch on the face and he's got twitching on the right hand. He gets this for about 10 seconds. And this happens about 15-20 times in a day, all reports normal. This is basically epilepsia partialis continua. This is called as EPC. Okay, what was the test that we didn't do in this and what is the test, one test that you would like to do? MRI normal, EEG normal. Young boy. Even I didn't do it. I did it because his events were just not stopping. Gave 3 antiepileptics. I didn't do it. Simple test. Hyperglycemia. This guy had 450 sugars. So whenever you have a seizure, particularly a focal seizure, hyperglycemia and hypoglycemia, always check a bedside sugar. It's very, very important. Before you do MRI, EEG in any seizure, first seizure, what is important is checking sugars. So nothing we did. We just gave him normal saline, hydrated him, corrected his sugars, and the seizure stopped by its own. So sugar checking is very, very important. So always remember, these are the common causes of epilepsia partialis continua. Hypoglycemia, hyperglycemia, put it in red, which are common. So always try to remember these few causes of EPC. This is called as epilepsia partialis continua. Just a focal, small focal seizure. It just continues, stops 15-20 episodes they'll get in a day. So remember this EPC. Now, case 5, a rare but not so rare seizure. Something which you should not miss though. So this 16-year-old girl, first GTCS, examination normal, no family history, no past history, MR normal, EEG normal. She was started on Eptoin by the family physician and referred to us. After starting Eptoin, she gets 2 more seizures. Very unusual, isn't it? First seizure, ने दवा तो चालू कर दिया, फिर भी उसको seizure आया, and she went into status epilepticus. What is one question that you would want to ask in history? Look at her video. Look at her carefully. It's a pretty long, it's a slightly long video, minute and a half. See what you can notice. I'll show you where she's getting a problem. See, she got a jerk. Did you see that? She got a very brief jerk. We'll see the jerk again. It will come towards the end of the video, maybe 30 seconds more. But she's not completely oriented while eating. She's a little confused when she's eating. See, she got another jerk. She's pushing her plate here and there. Now she's okay. Now she's awake. Look carefully. It's a long video. Look carefully. Now look. See, she's a little confused still. She's not able to eat properly. Got this joke? One more she'll get now. You saw that? Yeah, so that is called as myoclonus. So this is an epilepsy syndrome called as juvenile myoclonic epilepsy. What is important here to understand is there are only 3 drugs which act in this: valproic acid, levetiracetam, and clobazam. You give Eptoin, carbamazepine, they will deteriorate. So this is an epilepsy syndrome. Will you treat this? Because you've diagnosed an epilepsy syndrome. So that was the 3rd definition of that epilepsy thing. So this is lifelong treatment. And what is important is only 3 drugs act. दूसरा कुछ भी देगा तो खराब हो जाएगा. So always remember this. Now look at this. So this is a young girl. She was addicted to taking selfies. Somebody is clicking her selfie. She's laughing. She's smiling. Keep looking at the video. Right. So she's laughing quite vigorously. And now she's gone into a stare. She's having some oral movements. And she's confused. And now she's back to normal, getting her selfie clicked. Okay, now look at this video. She's been asked to hyperventilate. Now look at her. She's been asked to hyperventilate. She's hyperventilating. And now she's gone. She stops hyperventilating. Look at her mouth. She's having this lip smacking movements. Something with the hand she is doing. And now she's normal again, started hyperventilating. Diagnosis? Absence, yes. So sir is right. Absence epilepsy. This is again a video of absence. I'll skip because that was pretty evident. So this is again an epilepsy syndrome. Will you treat this? It has to be treated lifelong. So it is absence seizures. Again, what is important here, why I mentioned only these two, there are a lot of syndromes, sir would know, a lot of syndromes are there, but these two are very common. And why it is important is because these two syndromes respond only to certain drugs. So absence, the drug of choice is ethosuximide, and second is valproic acid. This girl was put on levetiracetam. She continued to have events because it doesn't work. There are only two drugs, ethosuximide and valproic acid. There's nothing else that works. So these are two epilepsy syndromes which you should not miss. Okay. So now, putting everything into perspective, you have a new onset seizure. You classify as provoked or unprovoked. If it is a provoked seizure, will you start anti-epileptic? Preferably not until and unless the patient is critically ill. The patient had multiple or prolonged seizures, thoda din ke liye de sakte hai, but the underlying cause has to be treated. So if you say uska hyponatremia में 4-5 दिन तक रहने वाला है, हम फास्ट करेंगे, तो 4-5 दिन तक anti-epileptic दे सकते हैं. And if it is an unprovoked seizure, if the seizure occurred in sleep, if there is a remote symptomatic history of brain injury, imaging shows abnormality, neurological examination or EEG shows abnormality, start medications, okay? Now, this is 3 videos that I'm showing you. Just look at these movements. All 3 patients, they came with only one history, 6 months history of dementia. You look at this lady again. Did you note, look at this gentleman? You're seeing that jerk? You're seeing that jerk? He's having these jerks. And now look at the third video. All 3 rapidly progressive dementia, 6 months, MRI normal, EEG normal, nothing is there. And suddenly he gets up with a myoclonic jerk. So elderly, rapidly progressive dementia with these jerks, there's an entity called as faciobrachial dystonic seizure, which is seen in LG1 encephalitis, that is VGKC encephalitis. It is completely treatable. The dementia improves, the seizures improve. So don't miss this autoimmune epilepsy. These are a few causes of seizures in the elderly. Do not miss. Okay. Now this is a 23-year-old female. Okay, I'll go ahead. Yeah. So now next is 23-year-old female, 3 days history, hyper-religiosity, agitation, crying spells, and repeatedly saying she will die. Itna history hai. No fever, headache, seizure, substance abuse, no episodes in the past. She was admitted at a tertiary care hospital and she was put in the psychiatry ward, multiple antipsychotics. Relatives came with 2 videos to me. MRI was normal, EEG was normal, CSF was normal. So look at the first video. So she's crying and what she's saying is, mar jaungi main. There's no audio, but what she's saying is, mar jaungi main, she's crying. Okay? And now look at the other video. Can you see the twitching, perioral twitching in the video? Yeah. So this is very, very classical of an autoimmune encephalitis disease called as NMDA receptor encephalitis. So her NMDA was positive. We treated her. There was a novel written on NMDA encephalitis known as brain on fire. It is seen in young girls. So acute onset psychiatric illness, always think of NMDA encephalitis. And after treatment, we sent her home and she went home walking. We treated her with plasmapheresis, didn't improve, gave IVIG, didn't improve, on steroid, didn't improve. Finally, after 3 weeks, we gave her Ritux and she went home after rituximab. And it is so rewarding. So all epilepsies are not uncurable. There are certain epilepsies which are curable. Now, very quickly, go to seizure mimics. Will be at least 5 years, then we see. Now, coming to seizure mimics, quickly, syncope, migraine, TIA, and psychogenic non-epileptic events. So this is a girl possessed, young female, no known comorbidities, recurrent fainting spells, clenching of teeth, pelvic thrusting. Episodes last for 1 to 2 hours. She is not responsive during the episode. She has lip bite, not tongue bite. MRI normal, EEG normal, was put on levetiracetam. And after starting levetiracetam, her symptoms worsened. She started getting 10 times in a day. That's her video. So, two things that I want you to notice. First is the pelvic thrusting that she is doing. It is pelvic thrusting that she is doing. And the second is, most of the time, her eyes were closed. Okay? Everything normal. Whenever you have pelvic thrusting and events occurring with eyes closed, it is not a seizure. It is non-epileptic. So how do you differentiate non-epileptic from epileptic events? Usually non-epileptic events are prolonged. This girl had 2 hours. She used to do this. 2 hours. Seizure cannot be 2 hours. Second is, it is fluctuating in non-epileptic events. मतलब आज ऐसा करेगी, कल से वैसा ही करेगी. परसों कुछ और करेगी, परसों रोएगी, तरसों कुछ और करेगी. So the events will keep fluctuating. Seizure are always stereotyped. You get 10 events, all 10 events will be same to same. There will be no change in the nature of the event. Yeah, 5 minutes, yes. I'll finish in 5 minutes. Usually during wakefulness, non-epileptic events, seizures occur mostly during sleep. Side to side head movements. ऐसा कोई कर रहा है, it is non-epileptic. Always remember, seizure is always like this. And somebody is doing like this, it is non-epileptic. For sure, crying during the event is non-epileptic. Seizure के time पे कोई रोता नहीं है. और pelvic thrusting is non-epileptic for sure, 100%. Is non-epileptic. There's no question. Incontinence, very rare in non-epileptic events. Tongue bite, they will have tip of the tongue bite in non-epileptic, side of the tongue in epilepsy. And frothing will never occur in non-epileptic events. Frothing has to occur in seizures. And the most important point is, when this patient comes to you and the relatives are talking and the patient is sitting in front of you, an epileptic patient will be very concerned about her illness. Whereas एक psychogenic non-epileptic को कोई लेना देना, वो इधर देख रहा है, relatives बात कर रहे हैं, मैं बात कर रहा हूँ. Okay, now elderly female, I have discussed this case. You must remember this case. 72-year-old, 3 days history, daily night events, headache followed by unresponsiveness for a few minutes. Labs normal, MRI, EEG, echo, ECG, all normal. She came to me, I put her on 2 and she was already on 1 anti-epileptic. I put her on 1 more. Next day she had 2-3 events more. And interictally she is normal. That's her video. So look at her. I feel. बस हो गया, इतना ही event. That's all. She says, आ रहा है, and she gets this like this, and that's gone. That's it. So she continued to have events. I started her on 2 antiepileptics. Next day again, they came. So I said, now you admit her, this doesn't look good. And they showed me the video the second day. And we did put her on a monitor, and the monitor showed a heart rate of. So this was basically a heart block. This is an arrhythmia, arrhythmogenic syncope. So in elderly, don't miss that. Now look at this video. This is a boy. So 2 mimics I showed you. One is non-epileptic. Second I showed you is cardiogenic. Now look at this. So this man in the black shirt, he's stretching himself. And he suddenly falls down. He stretched himself. You were doing this at the start of the video and he fell down. और अभी उठ के बैठ गया. So this is vasovagal, yes. So there is something which is called as stretch syncope. So this is very common. The point is, how do you differentiate a syncope from a seizure? Syncope usually will have a trigger. They will either stretch themselves, they will have some pain, they will see blood, they are standing in a queue, they are standing in a crowded train. It is very, very brief. Within seconds to minutes, they are up. There is usually no post-ictal confusion in syncope. They might get some jerks in syncope, but that's not seizure. So this is a few differences between syncope and seizure. We can discuss that some other time. So what are the red flags in syncope? Any syncope patient always do an ECG. So if the ECG is abnormal, it's a red flag. Syncope in a patient with heart disease. Syncope which occurs in seated position has to be cardiogenic. It cannot be vasovagal. बैठे-बैठे syncope आ रहा है, वो normal नहीं है. Syncope while driving, syncope while exercising, always be very, very careful. So ECG is extremely important while you deal with a syncope. And now the last case. So this guy came with left lower limb jerking, acute onset left lower limb jerking. And after the jerk, his left hand and leg used to become very weak. MRI normal, sugar normal, all reports normal, no comorbidities, except that he was a smoker. And one more video, look at this lady. These are the few events which she gets for 2-3 minutes and it stops on its own. MRI normal, 3 anti-epileptics were started by a neurologist, no relief, multiple events in a day. Any guesses what this is? This seizure mimic, what is it? There's something which is called as limb shaking TIA. So the MRI was normal because when the MRI was done, the patient was not having any event, but the angio showed a tight carotid artery stenosis. And the only treatment was carotid artery stenting. So limb shaking TIA is a mimic. There are 2 other mimics. I'll stop here because of the want of time. Migraine, always remember. And last is the last case. See this boy. See what he's doing. Is this a seizure? These are basically paroxysmal non-epileptic events. Okay. This is also called as paroxysmal kinesogenic dyskinesia. So this is very unusual. The treatment is, everything will be normal. The treatment is you give them benzodiazepines and carbamazepine sometimes works in this case, in these cases. So these are the 5 seizure mimics that I wanted to discuss. So I'll stop here. Thank you very much for the patient listening. Thank you.
So due to shortage of time, I think we'll be able to take just one question if anyone has.
Very often after the seizure, we don't do an EEG. So the EEG necessarily does not.
Yes.
What is the best time to do a seizure? We go down better when we have not witnessed the
So the best time to do that?
in the hand patient they will ready to take a night recovery.
Yeah.
When you next day the after not the only.
The best time to do an EEG is the earliest you do the EEG, there are chances that you'll pick up something. Suppose you're not very sure and the events are very infrequent, then what you can do is you put them for a prolonged EEG. But EEG is not the diagnostic test for seizure because more often than not 70% cases will be normal on EEG. So earlier the better.
So we are worried.
Yeah, you have to do an EEG, you have to offer them an EEG. But what I do is if they are very early into it, कल रात को वो आज सुबह आया है तो I do the EEG immediately. If it's been a week back or maybe even longer back, I tell them that you do a 3-hour EEG, आराम से करो, कोई घाई नहीं है. And if you're very convinced that it is an epilepsy, start the medicine. But then you do a prolonged EEG. But time is not very, very crucial. Earlier the better.
But is there any previous sometimes the EEG does not show anything but of the fact that the patient has got a seizure in front of.
Yes, correct. So that depends on where is the focus of the seizure. Now, EEG is basically an external electrode that you are putting. If the seizure is coming from some deep medial temporal lobe structure, that you will not pick up. That you will not pick up.
Thank you very much, sir. I'll request Dr. Nitin Dinesh, sir, to felicitate Dr. Dinesh Singh.
Right, thank you, sir.
That was wonderful talk, sir. Thank you so very much. Next, I'll